All right. Good morning. We'll get through my quick housekeeping things and then we'll turn it over to Alex. He's talking about collaborating with emergency medicine specialists for OUD treatment. Interesting topic this morning. Okay, usual disclosure of relationships. Again, nothing to disclose. This is a grant-funded project funded by the State Opioid Response Grant. Those grants come to us at the Nebraska Medical Association by way of Nebraska DHHS, and then we were able to make this project happen through those grant funds. Usual process for CME certificate. There'll be a brief evaluation survey that'll come to your email later this morning. That'll also be in the chat of this Zoom meeting. Just complete that quick evaluation survey, then I'll email out your certificate usually within a couple of business days. All right, so we do these echoes in rounds of four. So this is the fourth and final one from this current cycle. We'll be off in June while our team works on putting together some new trainings. We've got a couple lined up already. Todd's going to do one on GLP-1s and SUD treatment, an emerging topic. And then Stephanie's lined up to do one on the intersection of trauma, PTSD, and SUD. So a couple of good topics there, and we're just going to work on putting a couple more together, and then information will be coming out on that next cycle soon. As usual, you can click the button if you want to just automatically register for that next series, and I'll get you on the registration. And again, while we're off, just a reminder, consultations are available anytime. So if you're on this, you've got my contact info. Get in touch with me, and then I can connect you with one of our six experts. And I will let them introduce themselves now. Let's see, John, would you like to go first?
Hey, good morning, everybody. Uh, I'm John Massey, and I'm a pain doc here in Lincoln.
Thanks, John. Mary.
Good morning, Mary Ellis. I'm a psychiatric nurse practitioner and attorney in Nebraska.
Thanks, Mary. I don't see Todd or Ed or Stephanie on yet. I know a couple of them might be joining later. So I think, Alex, we will kick it over to you now.
Sorry, my Zoom things are going haywire here. Will you able to see my slides? Because I'm not able to right now. Okay, slideshow.
No, it says you've
Yeah, my
started
screen
screen.
sharing is paused, it says.
Oh, that's
Switch to
weird.
that desktop to continue sharing.
Huh.
Uh, okay, well, this is not going to be helpful. Uh,
Um,
I'm gonna
yeah, I don't
stop
know. I
sharing.
try it again. If we have to, I can run it for you.
Okay, let's see. So
There
there
it
we go.
goes.
Okay, so everybody can see Glock and Pluck in here.
Yes.
Okay, very good. All right, well, let's see, let me get this over here so I can see more on my screen. Um, this came about due to some recent experiences I've had, and also going back to my training. I was an intern admitting a long time ago, back when OxyContin drug reps were all over the place, and people were able to do, frankly, illegal and unethical things to get doctors to do unethical, if not illegal things, slinging these meds all over the place. The landscape has certainly changed, as we've talked about with kratom and fentanyl and nitazines and other things these days, as well as a different treatment landscape, which I'll touch on in a little bit in these slides. The my take on this is uh, the reason I mentioned being an intern is that I saw a friend come in who was having chronic back pain, and it was really drug dependence, and that person needed treatment. Thankfully, they got it and they have survived and are now doing great. But they were in the ER, and like trying to get help. And The ER was, not in a position to help them. I mean, just that for me has been emblematic of a lot of the ways our healthcare system is busted, and the way we as in the medical community and our patients have been manipulated and lied to. And Now when people like that was a chance to offer life-saving treatment, and the ER was not set up to do that. And now the ER can do that and should do that. And that's not just my opinion, that's ACEP's opinion. A lot of our colleagues, especially like, well, I would say statewide, but here in Omaha, a lot of our colleagues may be like, that's not my thing. Yes, it is. It's everybody's thing. And there's, again, a lot of ACEP literature to back this up. But My perspective is when somebody shows up with opioid use disorder in the ER, that's not that's not a great thing for the ER. I mean, it's I wish nobody had to deal with it. But the ER can start treatment, but they need the follow-up to be able to confidently do that and be able to tell a patient, I'm gonna get this going, and here's where you're gonna go, and you're gonna be okay. I mean, asking the ER to treat substance use disorders without backup from us and everybody really, but us, like the people on this call. It would be like asking them to treat heart attacks without the cath lab on backup, or not having cardiology around. It's like they can start it, but they need the next step. In this case, we are the people who can be that next step. So, and Let's see if I can get my slides to advance here. Okay. So, again, let's review a little bit of what ACEP says. They actually have a lot of literature on this. I tried to stay focused, not my strong suit. Talk about relationships, and then again, just as I think we all know, reiterate that we outside the ER are the best people to help the ER. Again, it belongs with us, but it can and should start in the emergency room. It should start wherever somebody shows up. That's a chance to save somebody's life. So this, again, like with many things, this should be all hands on deck. Let's help the emergency physician and their PAs and NPs. So, okay. So this was from the American College of Medical Toxicology subsection of the American College of Emergency Physicians. They support the administration of buprenorphine in the ER as a bridge to long-term addiction treatments. Furthermore, they support the administration of bupe to appropriate patients in the ER to treat withdrawal and reduce the risk of opioid overdose and death following discharge. So when my friend got discharged, eventually they made their way to the methadone clinic, which was life-saving for them, but they could have overdosed and died. Again, I looked up and was like, is that blankety blank? As I'm over there, like admitting four people. And then this, like, I couldn't even go over and say hi because I had too much going on. I didn't know if it'd be appropriate. I was like, ugh, what's going on over there? Again, there was a lot of that internalized shame, around problems being kind of, like someone's moral failing and like, oh, they're, a bad person or a dirty person or all that stuff. Again, a lot of more context of where our country has been and where we still need to get. Um, like this is their ER's current, like their professional society's current status. So if you are trying to build these relationships and anybody is at all hesitant, you can say like, oh, you might not have seen that there's a lot of literature and this is very much supported by your college. Did you know? Okay. Then quoting them, the ER can play a crucial role in the lives of patients with opioid use disorders and their families by offering treatment with buprenorphine. It needs to be supported by prompt access to ongoing treatment. That's where we come in, obviously. Again, people show up with overdoses. Obviously, that if you get Narcan, someone you should call 911. People will show up in withdrawal. That's what my friend was going through. They may show up with obviously complications of opioid use. I've seen people with endocarditis, getting their like third valve replacement on the third tricuspid valve. People with discitis and other bloodborne infections. They're in the hospital needing high dose opioids so they don't leave AMA and get sicker. Line infections, other medical complications, and then things go haywire because, like, well, can we discharge this person with the central line for their antibiotics when we know they're gonna, because we don't have a good treatment plan for their drug use? And then patients will get fired, but the hospital, still needs to admit them in the ER. You can't fire people from the ER. Like, you have to see them. So again, the things can either snowball into more and more badness, and then patients understandably have negative interactions with the healthcare system. They get judged, they get yelled at, they are, ignored. Their pain is not taken seriously because they can and will be in a lot of pain. And then that shockingly does not improve their odds of adherence and having pleasant interactions with future medical teams. Such as like when I would see somebody who'd been admitted a lot and I had never met him, but like both they and I had a lot of things preloaded about how this was likely to go because of everything that had gone before. Uh, this is a chance to not go down that rabbit hole of like negative spiraling interactions and help somebody do well. But again, if the ER is going to start this, they need to know they have some place where they can, hand them off. So, um, and again, a lot of, they say people at high risk. So people with Medicaid, people who are uninsured, people who have substance use disorders, people who have, social chaos, people who have housing instability, people who are being trafficked and abused. These people all are less likely to have, regular primary care. And so also, if we work to build these bridges with our ER colleagues, these folks can then, if they get in with us for opioid use disorder treatment, we can also do their health screenings. They'll get their cancer screenings done as age appropriate, get a mental health screening and treatment, referral to therapy. Diagnose and manage their high blood pressure, their diabetes, their whatever else they've got going. Maybe catch up on some childhood or chronic illness that, or injury that hasn't been addressed, and get them to ortho. I didn't think to put an ortho bro slide in here from Glockenflecken, but if they have bone problems, we can fix them. And again, just help them get their lives on track and get their health on track. Again, like we can also have some beneficial relationships here. And I've seen this in a lot of my other work with immigrants and refugees and queer folks, especially transgender people. Uh, Intersecting populations that have a lot of health barriers. People, with, housing stability after they're staying at the Stevens Center shelter next to the clinic where I work in South Omaha. Uh, People who have had a lot of marginalizing experiences because of who they are or what they've been through, where they get into care and they find somebody they can get comfortable with, then things kind of like their healthcare kind of blossoms and you can start to get their other conditions under control, start to help them with other things. Again, some of my patients living with HIV who feel very scared of, going up to the big hospital or, who've had negative experiences where that you start to be able to help form that relationship with the patient. And then things just kind of start snowballing in a good way. Like you start to get things under control, you get their needs met, get things handled. I'm thinking of another woman of color I take care of now who had been in the ER constantly, had been locked in by Medicaid, had been fired by other places and like had had a lot of trauma, lost a spouse, had had some medical trauma and like some racism that she'd experienced. And I was like, hi, I'm very white, but like I've been able to like interact with her and like we've gone from like everything is a huge mess when I inherited her to like spacing her visits out because she's doing good. And all that context to say that if somebody who is not doing great with an untreated opioid use disorder gets in with us, like and as primary care people or long-term specialists, we can start to help all these things, become good for them. And so the ER is also like not only are we trying to help them help the patient, which is what this is all about, but the ER is also potentially handing us like a golden opportunity on a platter to like have a hugely positive impact on this patient's life. And then like that can become a really fulfilling thing for us too. Like uh, I'm thinking of a patient that I take care of who happens to be gay, has had some negative health experiences and been discriminated against in his life before he met me, where like things went sideways with drugs, and then he got in care, and he eventually got his care stabilized with me on buprenorphine. It's a joy to see him. Like he's so great. He's like he's happy. Like he's been through a lot of stuff, but things are so much more positive for him, and he just absolutely thinks the world of me. And I'm just like, buddy, I'm just like, I'm just a primary care doctor. I mean, but like it's like he writes these nice notes in the portal, and like asks what I'm doing, with teaching and advocacy, and again, like it's a gift for me to see him. So not every consult's going to go like that. But again, I think this is something that is good for patients, again, first and foremost. it's a way for us to try to help our ER colleagues, but we can get a lot out of this too, to be clear. So, and then again, there's massive public health benefits to getting people with opioid use disorders into treatment. Uh, as I tell my trainees, like untreated opioid use disorders expose you to endocarditis, risky behaviors, maybe risky sex or risky relationships, maybe being caught in violence or trafficked or taken advantage of by unscrupulous people because you have a substance dependence and therefore you are vulnerable. And awful people very much know that and can target people to manipulate. And they probably do that more to women than men because everything is terrible. Medical complications like, all the infectious issues we talked about, overdose and death, like death, that's a big one. Law enforcement interactions, court and family disruption stuff, that would be obviously ideal for all concerned if, like a family being split up, like maybe necessary, to like help people get where they need to be. But boy, would it be nice if things never got to that point and families never had to be separated, right? And then like loss of jobs, loss of housing, like people's lives can just fall apart even if they do survive this, and they're not guaranteed to. So like, if we want to be like, just heartless, bastards and only think about like money and economic productivity, oh wait, this is all really good for that too. So I do not think anybody here is a heartless bastard. If you are, what are you doing here? But welcome. Like we're here for you too. So. Okay. And again, the ER should be part of an integrated response here. I don't know what each person's local emergency room is like. Some ER folks may still have the older perspective of like, nope, I'm not giving you drugs, get out of here. That there was even a song by Z-Dog, Zubin Damania, parodying Taylor Swift, if I remember right. That shows how culturally illiterate I am. I think it was Taylor Swift about we're never ever getting back together. But it was you go see your pain doctor or your PCP. We are never ever ever giving you drugs in the ER. And that was kind of a backlash to patients coming in and being like I want this and I want that and I want a side of fries to ER docs, which was not appropriate. However, seeing people who have a drug dependence and refusing to give them treatment, that's not appropriate either. That perspective has not aged well. The ER should be giving people buprenorphine, and due to some historical things that are their own kind of injustice, if you ask me. Methadone still needs to be given in a dingy brick building in the corner of a major city's downtown for purely legal reasons that I may have mentioned in one of my past talks, but they're not good or justified. You can't get methadone for addiction management or substance disorders. You can use it for pain, but the ER cannot start methadone. The ER and hospital are allowed to continue methadone if it is being given by a treatment program beforehand. But if someone shows up, that's not an option. And whatever we think of that, it's just not legal. I think again that's bad, but because it denies patients another option for what a condition that could literally kill them. That's like, well, you can cath them, but we're just going to administratively decide you can't stent them. That has to be done at the outside surgical hospital, not in them. You can't take them to the cath lab and do that from the ER. Like that would be crazy. Why is this any different? And politics from the 60s, if I recall the dates correctly. So. The ER can give buprenorphine. And again, if we can build these bridges and have this network for them to know they can send them to us for follow-up, I think they will. If the ER doesn't have that, like an enterprising ER doc may be like, well, this is what the position statement says, so I'm going to freaking do it. But I think that, again, they're a lot more likely to do that if instead of just being like, good luck, patient, like that's also not great. That doesn't put them in a great position. I don't think they're going to feel the best about that. It's very different. They're like, oh, go see, this person or that person. Hopefully, the people on this call, and they'll be like, yeah, we'll get them in. We'll make this happen. So again, just having that warm handoff and us being able to put them in treatment long term, get the rest of their healthcare going, and then the ER should also be screening Sometimes it's obvious. People may come in and say, "I have a drug problem." It's like, "Oh, thank you for being, thank you. Like, glad, let's help you with that." But the ER also should be screening to the extent that their capacity permits them, because there may be people who are not showing up advertising this or where it's obvious, but that's still part of why they're there. And then again, buprenorphine has a lot of safety, and again, it's less abusable. And when the alternative is fentanyl and 7-OH and meth that has fentanyl in it, or is just fentanyl, or nitazines, and who knows what else, designer chemicals, or thieneptine and other things, or all the above. Like, as I tell my trainees, like, uh, if we're thinking about harm reduction, is it safer for them to have this and like maybe try to misuse it, or I don't know, or like be on this, or safer to do, fentanyl or meth that is fentanyl, or the nitazines and all the, or like what's safer? The answer is always buprenorphine. Like there's never a situation where that is the more dangerous option given these alternatives and the landscape of what we're dealing with today. So, and again, this is like an official ACEP ACMT position. So if you're trying to make this outreach and you're getting any pushback from your friendly, bicycle wearing, Diet Coke slamming friends, again, hey, did you know? Like that didn't used to be the thing. Like when I was a trainee, that like there would have ER uh, that was not a supported position at all. But thankfully, like the X waiver and many other things, times have changed. So. Okay, so here are some ACAP resources, and I've put the link in here. Again, this is, as you can see, this is from their site. They've actually got quite a bit of stuff. And then I didn't have time to listen to this podcast here. I'm interested to know of what they're fighting about with Suboxone. Like, I presume, unless they put one of them up to like play the devil's advocate. It's like somebody needs Suboxone. Okay, good, do that. Next, that was a short podcast. Okay, and then they have this opioid summary guide, which is very well done, and it's got an overview of like morphine and like other mu kappa delta receptors, neuroanatomy and physiology. Talks about some of the risks of opioid use disorder, the rationale for Suboxone, how to get it started. And so I'm actually planning, like, because I have some PA students and residents, who are maybe thinking about emergency medicine or we're going to be moonlighting and covering ERs, especially as they go rural. And I'm like, I'm going to have them read this. Like, this is excellent. So, and I'm planning to leave some time for questions from the audience, but we can maybe go through that if needed. And again, this is in there. I went to this blog to find a bigger, higher quality image, but it's the exact same thing. And so it's like the emergency room initiating with the COWS clinical opioid withdrawal scale that I think we're familiar with. And if they're in mild withdrawal, then you probably don't want to start them on buprenorphine because of precipitated induction. And again, this actually is showing its age because this waiver thing is talking about the X waiver, which is back when you had to go get special training of 8 hours. And as I've joked many times, get a scarlet S for Suboxone sewn onto your scrubs to be marked out as one of the unclean who would do this or whatever. Like again, it caused a lot of stigma and was a literal barrier. And this compared to how much training I had to get to write, like to have patients come to me and asking for absurd amounts of Percocet or like, 500 plus morphine equivalents a day of OxyContin and oxycodone. Nothing. I had no like nobody ever like sat me down and talked about that. Like it was just a lot of like inertia. And so to do the safer thing for people in need as opposed to enable a substance problem or just be like, I can't help you and abandon patients, which were kind of the choices we were taught, versus like being able to give them what they need and what the evidence even then was saying was helpful. That was the complete opposite of what it should have been. And thankfully, the X waiver is in the trash bin of history where it belongs. Again, if you have a DEA and you can prescribe meds, you can prescribe Suboxone. So, again, referral for treatments, and you can allow somebody to do a home induction from the ER, or just refer them if they're. And again, this was when the ER docs, which ER doc is going to have an X waiver? None of them. So they'd have to like call people in. I remember I had to like go through a bunch of stuff to prescribe it inpatient to continue it for somebody, and they had to like document that I had done this, and like it took a couple of hours on a Saturday trying to get this. I'm like, the patient kind of needs it now, It was pure red tape and incredibly frustrating, and I'm glad it's gone. And then dosing, and then they can be observed in the ER, and then again, this doesn't matter anymore. This waivered stuff because again, we're free to do what the patient needs, which is good. Okay. And again, as I had foreshadowed and was already venting my frustration, there was a 72-hour rule. This was 2020. It used to be like you had to come back to the ER every single day, and then during COVID, it's like, oh, sure, let's soak up some more ER capacity. Like that is the dumbest possible move. The ER can prescribe. They could give people more meds because it's not like they're going to come back tomorrow and magically this went away. And that was tying up more ER capacity at the worst possible time. When they had other stuff going on, like for something that was again administrative and bureaucratic, not centered, not care driven. So we've gradually, a lot of the history of the United States' opioid use disorder treatment laws is us gradually doing less and less stupid, unhelpful things that get in the way of care. So this is all my editorializing. The views reflected in this rant are not those of Will Schmeckley or the NMA. They are solely those of Alex Dworak. But again, there's been some advocacy by ACAP to change that, which is good. And again, there should be interdisciplinary collaboration on this because we're all, again, hopefully rowing in the same direction with this. So, but again, they gotta know they gotta have somewhere where they can send them. And if we're reaching out proactively, especially if you're in a smaller locale, there's just the one ER. Like this should be pretty easy for us to do. So, and again, that's where you come in. So, and if you've already done this, amazing. You get all the bonus points. What do you need me here lecturing about this for? But I think this is a very good deal. So, and again, this starts with relationships. As with anything, whether it's like working with your local, ortho bro, or salt bro, with your patients on dialysis trying to get kidney transplants, whatever the case may be, like if you have a good, maybe say a friendly pain specialist or a psychiatrist who can help with some of these things, like I don't know, people on this call. Like if you've got that relationship already, and it's much easier to build on an existing relationship to make something happen than it is to start from scratch in the middle of something. Sometimes that's what you have to do too. But again, if you're already interacting with these people as an admitting or as part of your local medical community, again, maybe trying to get coffee or bring them a Diet Coke, and a Cliff Bar or something, just to say, hey, this is something that I am passionate about, that I'm learning about in this echo, or that I'm already doing, and we know that there's between the kratom and illegal drug, like there's so much stuff out there. When you see somebody with this, because you will, and we all already are, uh, if they're game for treatment, please start this and then get them to me, and like we'll make this happen. So. And so I have a couple of cases, and these are interactions. This was the softball. I got invited to lecture at the ER residency from the hospital where I trained at and where I still have a lot of connections. And a good friend of mine is one of the faculty that I've done a lot of NMA stuff with. And I tried over the years to say like, hey, can we collaborate here? As ACAP's positions have changed, I noticed a change in some of the other faculty to where they're like, nah, that's not really something we're interested in. To like, yes, let's do this. And again, this hospital has some outstanding addiction medicine specialists, but their capacity is kind of limited, and they take care of some really complicated things. And a lot of times, like, there's not that anybody who is dealing with a severe substance use disorder is ever like that simple or straightforward. But the main thing is like give them Suboxone and then but also like even in a sense, I think that family physicians like me and my PAs and NPs, like we by default think about the whole person. And like, so even compared to the addiction specialists, like we bring some different stuff to the table, or we're thinking more about their cancer screenings, if they have diabetes or they have, other stuff going on, like we're just like, yeah, we'll handle that. That's our thing. Uh, Again, for some of these folks who like the substance use disorder is their main problem, and that's relatively straightforward to manage, we might actually be in an even better position to help them if their uncontrolled diabetes and their hepatitis C and the syphilis that they got that they didn't know they had are also like we'll handle that. maybe my addiction medicine friends have been, developing other hobbies since I last talked to them, but I don't think they would get all that stuff handled there. But again, this should be, again, us all working together, all hands on deck. And in this case, we are able to provide a bit more capacity and more rapid access than our addiction medicine friends can, because we're not as booked out. And we're also outside the ivory tower in, the on the mean streets of South O. So we have a different set of resources and perspective. And again, for a lot of these patients who have other barriers, other social determinants of health, like that's one thing inside the ivory tower, like out on the streets, where we do our thing, like we're like, okay, yeah, that's normal. So again, different strengths, and we share patients with them, we talk to them. They're excellent helpers for questions, and I have called them more than once when things are very challenging from the substance use perspective. Again, all hands on deck. So again, after I lecture, I set up a meeting. I talk to some of these people who I know face to face, in the place where I trained, and their nurse now has my clinic nurse's back line. We've got a total of 8 family medicine and psychiatry people on site, as well as we just matched a couple more. So I think at least 6 family medicine continuity residents, or no, 2 more, including the sub interns who are staffed by faculty who are part of this hit squad of Suboxone champions, where there's a lot of us, and between all of us, like we're committed to like add this person on, double book them. They're being served up on a platter, so it's not going to be, that technically demanding for us. We know what they're there for. The patient wants this. It's not a hard add-on. And so between all of us, like we've made that commitment. You call us, we'll figure it out. We'll get them in. We will be that warm handoff. And again, importantly, this is not just me personally. Like this is not all falling on my shoulders. I have an excellent team of amazing people standing with me who I like. If I'm sick or out of town, like this doesn't all depend on me being there. When you do this, if you're talking to your local ER staff, like make sure you have a group so it's not all just on you personally, because that's not sustainable. So again, we also are fortunate to have LADAC and PLADAC therapists, and we've got our little program built out. If you're interested in building out a program like that, have Will connect you with me, and I'm happy to share what has worked well and what we've learned along the way to help you with that. So, okay, so that worked out great. Case 2, I recently I cold called another local ER where we know they see a lot of mental health and substance use because I do not perceive that their system has as much capacity. They don't have addiction medicine specialists on staff, and I do not know of any primary care people who are like me who are eagerly doing this. And again, that's a slightly different population, but because segregation and social determinants of health are real. Like, if anybody didn't believe me and you've never been to Omaha, like drive around North O versus South O versus West O versus Elkhorn versus Bellevue and Papillion, and then head down to Plattsmouth and tell me social determinants of health aren't real. They are. So, and again, different setup, but a lot of the same challenges. And again, there's also not a primary teaching program there, so like the faculty connection isn't quite as much there. I don't have any affiliations, so I cold called them saying like, "Hey, we did this at this other place. Like, can we do this with you?" And it's kind of been crickets. I I would call this a fail. But I am gonna like Boromir here. I am going to try again. So. I through one of my Suboxone champion friends who does surgical obstetrics too. Uh, she has a friend who has connections here and delivers babies there, and so I'm going to try to like leapfrog, talk to her, then talk to this other person, then use some other connections I made to talk here, and just see if I can come at it from a different angle and try to make this happen. This is what I do with my free time when I'm not putting together plastic Space Marines with my son or going to my daughter's softball game. So, okay. So again, I think that we're in a good position to help ER specialists when these things come up. And again, they can help us by feeding us patients who like need care, where we can do a lot for them, get a lot out of those relationships and interactions. And so again, like feel like a broken record. All hands on deck. Let's help the emergency physician. Uh, Us taking outreach and utilizing and or building relationships is key for that. Like there's a lot of like relationships by roles in medicine where like if I call up and ask for neurosurgery, even if it's not a neurosurgeon I personally met, there's an assumed level of both competence and training and perspective and willingness to interact just because we're in those roles together. Like we're the chess pieces on the board doing our thing. But for something like this, like getting to know the folks, like trying to get coffee, if you can, or something like that, or utilize existing relationships and connections, whether directly or indirectly, depending on the situation. I think that matters a lot to helping set this up, and then because it's easier for when it's 3 in the morning and they're seeing somebody and they're like burned out on adrenaline and stuff. It's one thing to be like, yeah, go see this faceless clinic and maybe they'll take care of you. And another thing to be like, no, actually, I talked to this, like weirdo with a beard and a ponytail. He's very passionate about this. His clinic wants to be there for you. They'll take care of you. That's how I'm hoping this goes with this other hospital. That's what my ER buddy at the first hospital might literally say. So, and again, you get to ACAP has shifted their position and has these resources, and like this is aggressively what they're in favor of. So if somebody is giving you the older, like, nah, we don't do that around here, you can be like, maybe you should like look at what your own professional position statement is, and like there's tools for it. And again, don't be scared. Like it's going to be okay. Because I think a lot of this, if you encounter resistance, is probably fear and stigma. Because I know that's what it was in my past interactions with other folks. And I know that's what it was for me. Like I had to do my own work of putting aside the fear and the stigma around treating folks who have drug problems and rehumanize them in my own brain. And so I can have some insight that other specialists who have not had the experiences and training and the connections that I have to bring me here, maybe they might need to do that work too, and we can help them with that. So, and then again, make sure you have the capacity and redundancy to where this doesn't just all fall on you. I think of another friend where when I was covering the hospital, the residents got a message back in the X-Waiver days where it was like a Saturday at night and there was a referral request I was like, yeah, as the attending, I'm like, yeah, I got an X-Waiver, I can send that. It became clear to me that the system in this clinic location was like just him. Like all the referral requests went to him. There was no proxying, there was no vacation coverage. Like it was just, and I was like, bro, you're gonna burn out. Like, don't do that. Like, get some help. And so, if you're gonna do this in your practice, like, please have some other connections so this doesn't all fall on you. So you're not getting, calls on weekends or paged on vacation or whatever. Again, without the X waiver, there's less of that nonsense. But again, when I made this offer to the local hospital, it wasn't just me. It was a whole team of, Avengers here. And so I hope you have support in your practice and other people in your community. And if not, again, I hope that things like this can help you build that. So, and again, going back to Glockenflecken, if anyone wants to help us perpetually bedraggled family physicians, again, we're not going to be mad. So, um, okay. So I think I saw something in the chats, and we've got about 20 minutes left. So I think this would be a good place for me to call it. And if anyone hasn't been to APOD, it is a joy in my life. And I maybe if I retire, I could eventually get good at astrophotography. One of my favorite books is written by a pathologist physician called Robert Gendler. Again, if you ever need like some cosmic wonder and joy in your life, NASA and people like him are there for you. So, okay. Let me take a look at the chat here. Yeah,
Thanks.
Joyce, 100%. This is collaborative. And again, giving the ER the knowledge that, like, yeah, we're here for you. But that's also part of what this echo is about, like giving you all the knowledge and the confidence, hopefully, if you don't already have it, and the support to be like, we're here for you too. And if you're like, I don't know what's going on here, like, light the bat signal or call the Avengers phone or I don't know, like page Captain Marvel, whatever movie metaphor we want to go with here. Um, so I will stop talking and refill my caffeine, which I desperately need to do. And I can either go through some of this ACAP stuff, Will, if there are not questions or cases, or if people do have questions and cases after I refill my caffeine, we can talk about that.
Perfect. Perfect. Yeah, feel free to drop questions in the chat or unmute. We'd also have time for a patient case if someone wants to share a patient case. So we can just pause here for a minute and see what comes up.
Will, I apologize for not taking 59 minutes and 12 seconds and talking a lot. I promise you this will never happen again.
No, no problem. This is
And
just
apologies
just
everybody for
great.
my voice. I have been extremely congested, and I actually feel better. I sound a little bit less terrible than I did yesterday, but my sonorous dulcet tones are not what they usually are. I actually have a strongman competition tomorrow, so I guess I'm glad I got started to get sick Monday instead of today because there's a the finale event is pushing and pulling a 700-pound sled, and I'm glad I will hopefully be able to breathe for that because that's going to be hard enough if I can breathe.
Wow. Yeah, so again, feel free to you're welcome to speak up if you want to ask questions, share cases.
Or if anyone wants to come out and cheer tomorrow, it's at the Granary Green in Ralston. Uh,
Nice.
and proceeds go to the 50-mile march, which is a Nebraska-based charity that supports mental health and I think substance use services for veterans, if I remember correctly. So,
Nice.
again, there's no spectator fee, but or if you just want to donate to 50-mile march, I'll see if I can throw that in there. I'm not sponsored by them, or I don't have any ulterior connections or whatever. But seems topical.
Nice. Okay, question for Mary. Are there better emergency departments to go to for collaborative care?
Um, so I was trying not to cast aspersions one way or the other. Yeah, and honestly, I have no aspersions to cast. Like, um, the ER that I was referring to is Nebraska Medicine. Like I trained there. I worked in I was in the ER constantly for like 13 years as an admitting with the family medicine service. Like the family, we have UNMC Family Med residents at One World, and like so I'm still connected with that program. For me, I would say that one because like again, they know me, I know them. Several classmates of mine are ER doctors. Again, like that. My friend Jordan Warcall is very active in the NMA and is one of the faculty. Like that was the biggest softball over the plate that one could ever have hoped for. So the other one I was talking about, if anybody knows anything about Omaha, I'm sure you knew that was Emmanuel, which is in North Omaha, where a lot of their psych stuff is too. And again, like they do a lot of very important work. Our patient populations overlap a lot, especially with One World's clinic on 90th and Maple, which is fairly close to Emmanuel. But again, I made an initial connection, but I'm sure they're busy. And again, I just like we don't know each other at all. The ER doc I tried to reach out to, like, there's none of that groundwork. Jordan and I have worked a lot on some different NMA things and have shared patients together and have some other common friends. Like again, it was like a slam dunk to oh wait, maybe I'll actually have to work to figure this out and be a bit persistent. And again, one of my friends and colleagues is good friends with someone who does surgical obstetrics at up there at Emmanuel. There's another connection I have with a former resident of mine, so I'm going to try to leverage those connections to see what else I can do to get something set up. But again, I don't think that anybody's like anti-collaborative care, but just this is kind of not just like advertising our services publicly, but like next level of like building that connection so that the ER doc is like, hey, like I'm going to hand you off to these people directly. Like that was kind of my goal here, which I've been hoping to do for like since I started Suboxone because I saw like people with uncontrolled like opioid problems and the complications as a hospitalist, and I'm like, okay, that like what can we do to like get this at like where it belongs, which is not in the ER. Like if they're in the ER, like we've kind of failed. but that's another touch point. That's another chance. And ideally to avoid what happened to my friend, which was to show up in the ER with an opioid problem and basically get turned away, which was, no shade like on the ER people who saw him, whoever they were, like that was just what you did at that time. Like there was a lot of stigma, and like you would have gotten yelled at and called into your boss's office, or maybe like even got written up for unprofessional behavior, or who knows what. If you were an ER doc treating, opioid use disorders, like you would be looked at as like feeding the problem because of all the stupid, moralizing and stigma around it at that point. So. Okay, and then Joyce, appreciate that. Yeah, I have some site connections. Again, I that's another like avenue that I think I will look at. And again, I also don't really have a sense that they like. I don't know if their psych people do a lot of Suboxone there. I again am not aware of any family med or internal medicine people. I got invited to lecture to the internal medicine docs about this because at Creighton a while back because none of them like know how to do it. Maybe that has changed. I would love it if I was wrong because again, this should not be. This would be like like there's only one family doc who prescribes Ozempic, or there's only one family doc who prescribes insulin. I'm like, what? That's crazy. Or there's only two docs in Nebraska who take care of trans kids. Oh wait, that's real. But again, a large hospital system should have plenty of capacity. I think that the only reason it doesn't is, like I said, fear, stigma, and I wouldn't say lack of education because the education's out there. Like you can go get it. So then, Pat, the broader written protocols for starting people in the ER. Yeah, that's a great question, and this is part of what I had in mind. Like because again, like I and it kind of my own volition took up Mark Malyard's mantle of like wanting to eliminate hepatitis C across Nebraska. He was a GI doc who was one of my teachers, and this goes hand in hand with that. And again, here in Omaha, like we have a lot of support. I very much have rural docs like you and others in mind with like, okay, how do I support this? Um, so yeah, I think starting with 4 to 8 and that algorithm I think is pretty helpful because if somebody's in mild withdrawal, you can set the ER can say like if we start now, we could kind of the Suboxone will come in and like punch the morphine or the fentanyl off your receptors, and you'll go into withdrawal. I think that's that protocol of holding if it's mild, but again knowing that our clinic will get them in, or starting and observing if they are in withdrawal as objectively assessed by the cow scale can be helpful. There's also applying a patch for microinduction with a plan to come in and get them on treatment, which I've had success with one patient with kratom for that, but not with somebody who was using more 7-OH, which is more potent, which is relevant to what Ed talked about recently. And so to answer your question, there's those ACEP statements, but Pat, I'd be happy to talk with you about like patch microinductions and like ways your ER team could do that and then get them to you and your group. So Will, I don't know if you'd maybe be willing to email us because I need to run to clinic after this and I'm worried I will forget because that's how my brain works. And then Pat, maybe we can talk further about this. And if we figure something like I'll do some more reading. I can maybe try to knock something together to get to you, and maybe we could share it out with the larger group if there's interest. So, no, Pat, I think you're muted.
So that sounds good. I'll reach out to Will
Perfect.
and work
Yeah,
on
no,
that.
like again, this would make me very happy if I can like have like as a Nebraska family doc, knowing that like I'm in the little big city and that many of my brethren are not. Like, yeah, I would be thrilled to try to help you with that. And if it's something that seems useful and we share it out further, awesome. Because
Great,
I know that
thanks.
I only got where I got because I had other people help me this way because my training utterly failed to prepare me for this, as I'm sure it did you and most of us on this call.
Yeah.
Great, great. I'll make sure that you two are able to get connected. Um,
Thanks, Will.
yeah, thank you. That's kind of what Echo's about is doing
Yeah.
those types of consultations. So thanks, Alex.
Mhm.
Yeah, let's see, we got a few minutes left. Any further questions, comments for Alex?
I can start rotating through my impressions of the different Glaucomflecken hospital doctors, except the OB-GYN. Like, wait, a woman? That's literally the tagline on Glaucomflecken's website. Um,
While we're waiting, I'm going to drop in the link to the evaluation survey right now, so you can do that now. You can grab that now and get your name on the list, my email list for certificates, or it'll also come out in an email later here.
okay.
So yeah, I'm not seeing much else. Do we want to call it early, Alex?
I mean, I can hang out for a couple more minutes before I have to run to
Okay.
clinic, but yeah,
Okay.
I'm thinking of some of the different resources I've used to start putting that together for Dr. Hodavi. Yeah, again, I appreciate everybody allowing me to come in and like as I've explained, this is personal to me, both in my professional capacity and in my friend circle. I think most of us have our lives have been touched by this if we look hard enough, or maybe they have been and we don't even know it because somebody made it through. Um, and Again, I think this is like there's the how to, but then I think this is more of like okay, so what do we do with this knowledge, and go further to again hopefully support our trusted local colleagues who again will be put in this position probably not by choice when this comes up, but like again that's a touch point and a chance to help somebody. And so if the ER people like know that they have this, like if we've built this relationship and this infrastructure and we've educated them, like, yeah, we will help you, and then here's what you can do, but get them to us, and then we'll take it from there. Like we want to, and we're able and willing. Like I think that will increase their comfort. And even if they're like, I'm not sure, but like go here, like that's like these people. I've talked to this doctor about it. This PA, this NP, like they're passionate about it. They know what they're doing. If like one person finds their way in because of some networking that we've tried here, and that one life gets saved, well, that it's like that story that I used to think was very silly and twee, but actually is kind of impactful. There was a person, a kid who saw a person like walking down the beach throwing starfish back into the ocean. They're like, well, they walked up, hey, what are you doing? Well, I'm trying to save these starfish. They're like, well, look how many there are, and the beach is so big, you're never gonna, you're never gonna save them all, And they're like, well, yeet, and they throw in like, I saved that one. And so again, if it's your loved one or your child or your parents, like boy, is that a big deal to you that they got saved. So again, if one person gets into treatment because of this and because of some outreach, not like not just me, but like all of us here might do with our local ER folks, you know, well, great success.
Well said. Very well said. I think we can call it a day there. Thanks so much, Alex. And like
Yeah,
Alex said, get in touch with us if you're interested in kind of exploring this more, and I can connect you with Alex.
thanks everybody.
Yep. Thank you. Have a good Friday. And then Echo Team, if you guys want to jump over to that other link, we'll do our team meeting. Thanks.